We do have lots of new and exciting treatments that are happening in melanoma, more so even in the last couple years. And I can tell you I did a similar talk to this about 2 years ago, and when I looked at my slides to make the new ones for this year, I couldn't believe how many things were already different just from 2 years ago. And I had to change most of the slides. So that's always a good thing. So just to give you a little bit of an outline in terms of what we're going to talk about, we're going to talk a little bit about adjuvant treatment and what's happening in that area. We're going to talk a little bit about clinical trials and what clinical trials are and the different types of clinical trials, so that you have a sense of when you're reading about some of the new developments that are happening in melanoma. We'll talk about some of these new treatments that are coming down the pipeline for melanoma, as well as some of the side effects that are associated with them. And we'll also talk about what new treatments are going to be available in terms of clinical trials and otherwise. So just to start off with a few key facts, and I know you've heard from a few other health professionals already, and certainly the treatment of melanoma is multidisciplinary. It involves a lot of different doctors and a lot of different healthcare professionals, and certainly those of you that have been in our clinics, you know that there's dermatologists and surgeons and medical oncologists and plastic surgeons and nurses and all kinds of different people that are involved in the care. Luckily, for most melanomas, because they're caught fairly early, the 5-year survival is about 90%. Metastatic disease, unfortunately, once it's spread, has always been thought as being generally incurable. However, hopefully this is now changing with some of the new therapies that we have. We've never had great response rates with radiation or chemotherapy. However, some of the radiation techniques have also changed over the years, and certainly we're seeing much better results with radiation than we used to years ago. And up until about 4 years ago, we had one drug that we used to treat metastatic melanoma, and that was a chemotherapy called DTIC, or dacarbazine, and you'll see as we go on through the talk that there's many others that are now available. And Dr. Wright touched on a little bit of the molecular classifications of melanoma and some of the new mutations that we test, and really the research that's gone on in this area, as well as the immune system and some of the new immunotherapies, has really changed how we treat melanoma now compared to 5 years ago. Okay, so we'll start off a little bit with the adjuvant therapy in melanoma. And what we mean by adjuvant therapy is that it's additional treatment that we give after you've had all your surgery, where we think that all the disease that was seen has been removed. But we know that there's still a risk of the disease coming back, because we know that there's probably microscopic cells that have traveled around and they're there in your body. And so we give therapy to try and reduce the risk of something happening down the road. Over the last 20 years, there's been a lot of treatments that have been looked at in this area. Things like BCG, levamisole, interleukin-2, interferon, which we've heard a little bit about today, chemotherapies. And really, even though they've tested all these different drugs, the only thing so far that's been shown to have an improvement, even though it's a small benefit, is a high-dose interferon. And that's why we're still using this drug. So when do we discuss adjuvant therapy, and who should be getting adjuvant treatment? Well, we look at some of the features of the melanoma that would increase the risk of the melanoma coming back or spreading sometime in the future. And basically there's 4 important things that we look at. How deep the melanoma is. Usually the deep melanomas that are greater than 4 millimeters deep are the ones we consider for therapy. Whether or not there's ulceration in the melanoma, and all this comes mostly from the pathology report that we get. The ulceration tends to make the melanoma a little more aggressive if it's there. Whether or not there's lymph nodes involved, and Dr. Wright talked a little bit about that earlier. And then there's something new over the last couple years called mitotic rate, which we're still trying to sort out how important this is in lieu of all these other things. And basically, these features are what guide us to decide whether or not we need to do any adjuvant therapy. And in general, patients who we discuss adjuvant therapy with are those patients that either have the lymph nodes involved or they have a very deep melanoma. And then we would discuss what therapies would be available. And in general, are the one therapy that we still have available is high-dose interferon. There are other therapies that are part of clinical trials that we'll talk about a little bit, but in general, the high-dose interferon is 1 year of therapy. There's 2 parts to it. First part where we give big doses of high-dose interferon daily for about 20 treatments, and then there's injections that patients do themselves under the skin for the rest of the 11 months. The side effects from this drug are quite tough, mostly flu-like symptoms, and someone was asking about the interferon earlier on, and basically because of the way it works is a little bit different than how we think about standard chemotherapy. So in terms of standard chemotherapy, we always think about losing your hair and feeling really nauseous and feeling really sick. The way interferon works is that it works by boosting your immune system, so that the side effects that you get from it are more related to your immune system being activated and not really the effects it has on all the different cells in your body. And so because of that, it makes you feel like you have a really bad flu. So mostly fevers and chills, headaches, feeling run down, feeling tired. Can also affect your liver and your blood counts, and so we watch out for those. And the question about depression and how it causes depression, there has been a lot of studies looking into this, and what the thought is that even though the main function of interferon is by affecting your immune system, that it also affects the chemicals in your brain, and affects the chemicals in the brain, some of the neuroreceptors and so on, and by doing that, it causes depression. So it's not anything that you personally would have any control over, unfortunately. It's just one of the side effects that can happen with high-dose interferon. And it can happen in about 10 to 15% of patients, so it is something that we watch for in our clinics. The benefit of the interferon, even though it's not a huge benefit, it can decrease the risk of recurrence by about 25%. And if we look at absolute numbers, the risk of reducing the risk is about 7%, and it improves overall survival by about 3%. So because the benefit isn't great, then we always think about what can we do to make that better, and the way to make that better is to use whatever new drugs are out there that are being tested and test those in patients that would require adjuvant therapy and see if they work. And we do this by doing clinical trials. And so I thought I would just spend a couple of minutes just talking a little bit about what the different clinical trials are, so that if you're ever approached to be part of a clinical trial, you have a better sense of what these trials are all about. So there's different types of clinical trials. There's ones that we call phase 1 clinical trials, and these are usually the very first trials that are being tested on humans. So that prior to that, they've done lots of work in the lab, looking at the drugs, looking at what effects the drugs might have, and then these are the first trials that are tested on humans. Usually, these trials aren't so specific that they would just be on melanoma patients. They often do a whole bunch of different cancer types, and they use these trials to figure out what the best dose would be, what some of the side effects are, and then see whether or not they work in certain types of cancers, and if they do, then they move on to bigger trials. And then the next trial they would move on to would be the phase 2 trials. And the phase 2 trials are bigger trials than what the phase 1s are, and these are done more specifically in a certain type of cancer, so that it would be all melanoma patients. They would test the doses that they figured out in the trial before, and they would look for how well this drug works, what the toxicity is, what kind of side effects people are experiencing. And then from there, if it does work, they would move on to much bigger trials if they see good results. And these bigger trials are the phase 3 trials that many of you, I'm sure, have participated in here at our center or possibly somewhere else. And these are the big trials where there's large numbers of patients, and you saw some of the ones that Dr. Wright was talking about, where sometimes there's thousands of patients. For the melanoma phase 3 trials, often they're in the 700 to 800 patient range, sometimes bigger. And these drugs involved, usually they're randomized where you don't get a choice of which treatment you get, and you're usually put into one group or the other. And the standard for these types of phase 3 trials is that they want to compare a new drug or a new therapy to what is considered standard therapy that we're already using. And sometimes when there isn't a standard, then they're compared to placebo. And these are usually the big trials that lead to drugs being approved and used for therapy. Okay. So I just wanted to put this up here just to give you a sense of some of the different drugs and different things that are happening. Dr. Wright mentioned a little bit about the molecular classification of melanoma, and basically the mutations that we're going to talk about and what that we test for in melanoma are basically these top three: the c-KIT, the NRAS, and BRAF that Dr. Wright had mentioned about. And what this pathway shows you, it shows you a couple of the survival pathways that are important in melanoma. And there's been a lot of work that's gone into this in the last 10 years, looking at these pathways. And basically what these pathways are pathways that exist within the melanoma cells that really drive the melanoma cells to grow and proliferate and spread elsewhere, okay? And these are the different parts of those pathways that are involved. And now there's drugs that have been developed for each of these different parts of the pathway, because the thought is if we can block one of these, or sometimes two of these, we can stop the melanoma cells from growing. Okay, and we'll talk about some of the drugs that are out there, and you can see that all these different parts of the pathway, there's lots of different drugs that are being developed and tested in clinical trials, so that just like the ones we have now for BRAF and MEK, hopefully we'll have others that affect different parts of the pathways. Okay, and as Dr. Wright mentioned, the three common ones that I highlighted here in red are the ones that we currently use in the clinics that help us guide what kind of therapy we're going to use for each patient. And so one of the first things we do when we see a patient is we send off their melanoma to have these three things tested. Okay, and there's about 45% of melanomas that will have BRAF mutations, about 20% that will have NRAS, and about 5 to 10% of the acral lentiginous melanomas that Dr. Wright mentioned, the ones under the nail beds and on the feet and hands, and the mucosal melanomas, which are the ones that you find inside the mouth, sometimes in the bowel and other areas. So in terms of, in the adjuvant setting, as I mentioned, interferon, we know it works, but it doesn't work that well, and because of that, there's always trials going on trying to find other drugs that potentially could work better. There is one trial that's currently ongoing, mostly in Europe, that's looking at a different form of interferon, specifically looking at ulcerated melanomas that do not have lymph nodes that are involved, because we know that the ulceration part of the melanoma can cause the melanomas to be higher risk. And so they're looking at whether giving interferon in this setting is helpful or not. One of the other trials that's currently going on with two immunotherapy drugs that we'll talk a little bit more about is a trial looking at ipilimumab compared to nivolumab in high-risk melanoma patients that have lymph node involvement. And this is testing these two new immunotherapies, and we'll spend a little bit more time talking about this. The great thing about once all these drugs get developed and they're tested in the metastatic setting, if they work, then they get moved on into earlier trials for patients that are stage 2 or stage 3. And that's really where hopefully we can see the majority of the benefit. And then the BRAF inhibitors that Dr. Wright had mentioned and someone had asked about trials in this area. So there are trials that are going on currently. We had these trials here at our center. The vemurafenib compared to placebo is still ongoing. The dabrafenib and trametinib versus placebo has now closed. And this is a good example of one of the trials that I mentioned to you where sometimes they're compared to placebo. And the reason for this, because we have this discussion all the time in the clinics, is because in some countries they don't really use interferon. So North America is one of the few countries that actually, one of the few continents that actually uses interferon to treat melanoma. In Europe, it's not that widely used. And so because this is a trial that's going on all over the world, the comparator arm is actually the placebo because not everybody uses interferon. We have a new trial that's upcoming looking at another type of immunotherapy called pembrolizumab compared to interferon, and that should be opening here in the next few months. I know these drugs sound like they're very, very complicated. It took me a lot of practice to learn how to say them all. I practiced that night. Okay, so we'll move on to the metastatic melanoma, because this is really where most of the new therapies are now being used, and because of that, they're being moved on to the adjuvant setting. So as Dr. Wright went through some of this, but really in terms of how we treat metastatic melanoma, and when we're talking about metastatic melanoma, we're talking about melanoma that is stage 4. That means it has spread to far away from the original site and from the lymph nodes where it started out. Okay? Despite all our new treatments, still our standard of care at our center and many centers across Canada is really participation in a clinical trial. And the reason for that is, even though we have all these new drugs and all these great drugs, we still have room to improve. And there's lots of research going into combination of these new drugs to even try and make things better. Outside of a clinical trial, the treatment options would be surgical resection, and Dr. Wright showed some data on this. So if you do have one spot in the lung or one spot in the liver that we could potentially remove with surgery, then that's always an option, and we work very closely with all our surgeons for these types of treatments. If you happen to have a BRAF mutation on your melanoma, then you have the option for BRAF and MEK inhibitors, which are the vemurafenib, dabrafenib, and trametinib. And then we have the immunotherapies, such as the ipilimumab, pembrolizumab, and nivolumab, and we still have chemotherapy, though we tend not to use it as often now that we have all these other options, but we do still use chemotherapy for down the road. Okay, so what's changed since 2011? As I told you, I had to modify all these slides and add on new drugs. So since 2011, we now have 6 drugs that have shown an improvement in overall survival in metastatic melanoma. So what that means is that we have 6 drugs that have actually shown to make melanoma patients live longer with metastatic disease. And 2 of these are BRAF inhibitors, the vemurafenib and the dabrafenib. Trametinib, which is a MEK inhibitor, we also use for BRAF melanomas. And then we now have 3 immunotherapy drugs. The ipilimumab, which was approved back in 2011. Pembrolizumab just got Health Canada approval a few weeks ago. And nivolumab is in the process of getting approval through Health Canada. And basically, all of these drugs, as I mentioned, the 5 drugs have been approved. 1 is still waiting. 4 of them are now funded, and the pembrolizumab and the nivolumab, the 2 immunotherapy drugs, are now going through the system in terms of funding in Canada. So this has really changed how we treat metastatic melanoma. So as I mentioned before, everyone gets their BRAF, NRAS, and c-KIT done, so that would give us an idea of what kind of drugs may work better to treat the melanoma. Clinical trial is always first and foremost if we have a trial that we think would give you a better chance than just being on standard therapy alone. And then in terms of what options you have, if you happen to be BRAF positive, then you always have the options for all the BRAF treatments. If not, then we have the other therapies, such as the immunotherapies and the chemotherapies. And then we now have options. If the first treatment you had didn't work, we have options to move on to secondary treatments, which include, again, some of the BRAF inhibitors and the immunotherapies, and even third-line treatments, and potentially even fourth-line treatments, which is a huge change from what we had only about 4 years ago, where we basically had chemotherapy and none of these other drugs. So in terms of chemotherapy unfortunately has never shown an improvement in overall survival. It has shown that it does work to shrink the cancers for a certain period of time, and in a very few patients, probably in about 2 to 3% of patients, this effect can last many, many years. But for the majority of patients, unfortunately, chemotherapy tends not to work for a very long time. We do still use it for treatments, depending on what the situation is, especially for somebody who has a lot of disease that we want to control quickly. We can always use chemotherapy to help us reduce the disease burden before we go on to something else. And then in terms of the BRAF inhibitors, as I mentioned, there's 2 that are that we use on a regular basis. The nice thing about these drugs is that they're both oral drugs. They're pills that you can take at home. So you get a prescription, you take them at home, and then you come back and see us 4 to 6 weeks later and see how you're doing. There is a few others that are currently in development, which, to be honest, work about the same as these ones do. But the nice thing about having other options is that if for whatever reason you didn't tolerate these ones, then at least we have other options and other drugs that we can use. These drugs tend to work very well. They work quickly and usually work in about 80% of people where they shrink down the tumors. And I think Dr. Wright mentioned this a little bit. Even though they work really well, often what happens is that the cancers become resistant to these drugs. And so because of this, the benefit tends not to last as long as what we would like. So there's been a lot of research looking at, can we improve this? Can we make the benefits last longer? And the answer is yes, by combining the drugs, by combining several drugs that target different parts of that pathway that I showed you earlier, so that instead of targeting one spot in the pathway, if we target 2 or 3 spots, then that tends to work a little bit better. And so we've done that with the combination of the dabrafenib and trametinib, which is really now our standard for patients who have BRAF mutated melanomas in terms of one of our first choices that we would use. And the reason for this is because we know it works better in terms of reducing the tumors. It works for a much longer time, usually about 12 to 13 months compared to 11 months with single agent like dabrafenib. And we know that you live longer if you have double therapy instead of single therapy. And the average survival is just over 2 years with these drugs. So what that tells us is that obviously if this is an average, there's lots of people that tend to do much better than those 2 years, and unfortunately some people that tend not to do as well. But because of these results, this is now our new standard in what we use in combination. However, if you didn't tolerate the combination, then obviously there's other options in terms of either single agents, or there's some new drugs that are currently going through that we'll have options for in the future. And then just to spend a couple of minutes on the NRAS mutation. The NRAS mutation, as if you remember from the previous little algorithm we had, we test BRAF, NRAS, and c-KIT. So NRAS is one of the things that we test, and this mutation is there in about 20% of patients. Currently we don't have a drug that's specific for this mutated melanoma. However, there's drugs that were tested in clinical trials, which just completed a few months ago, and we had that trial here at our center. And so we're waiting for the results of those trials to see if we will have a drug that we can use for this population of patients. And then for the c-KIT, when I showed you that the pathway chart, the c-KIT is involved in earlier development, so it's one of the mutations that actually is there when the melanocytes are just developing. And as I mentioned, these are important for the acral and the mucosal types of melanomas. And they've done lots of studies looking at different drugs that could target this mutation, and we're still waiting for some of those results. We do have one drug called imatinib or Gleevec that we know works in this population of patients, so we do use this to treat patients that have c-KIT mutations. And so we'll move on and spend a little bit of time on the immunotherapy, because this is really where cancer therapy is being revolutionized, and not just in melanoma, but many other cancers. And I was thinking a little bit about this when Noreen was up here, and she was talking about the dandelions, and and wouldn't it be great if we had something that worked well for a lot of different people? Well, one of the common denominators that we have between all kinds of different cancers and all kinds of different people is your immune system. So many of these new therapies work to target your immune system, and specifically the T cells, which are part of your white blood cells in your immune system. And what the T cells do is that their primary function in your body is to hunt down and destroy any cells that are either infected with bacteria or different germs, or even cells that have become cancerous. But in order for them to do this, the body has several mechanisms built in that can also shut down the T cells so that they don't keep going and going and going and cause problems with autoimmune type diseases. And so what a lot of the research has sort of focused on in the last several years is looking at these inhibitory molecules that are on the T cells, which are the molecules that will shut down the T cells, and looking at how can we block these so that the immune system can keep going and do a better job at going after the cancer cells, basically. So far we have drugs that target two of these inhibitory ligands that are expressed on this is a T cell here. I tried to find a very simple cartoon, but none of them are really that simple because this is much more complicated even than what's shown here. If this is a T cell, once the T cell gets activated because it sees something in the environment that it doesn't like, for instance, it shows things like CTLA4, which is a molecule that's found on the T cells, and this molecule is the key negative regulator, which is one of the things that will shut down the T cell once its job is done. And so ipilimumab, which is one of the new immunotherapies, it was designed to block this CTLA4 so that the T cell response can keep going and going and going and go after more cells. And the PD-1 does the same thing. PD-1, which is over here on this side, when the T cell sees a tumor cell, it starts expressing the PD-1, but the tumor cell has another ligand called PD-L1, which will shut this down and prevent the T cell from going after the tumor cells. So what these new drugs, such as the nivolumab and pembrolizumab, are doing is that they block this receptor and they allow the T cells to keep going and going and proliferate and go after the tumor cells. So a lot of the side effects that we get from these drugs are very, very different than what we're used to with the chemotherapies that we have now, and we'll talk a little bit about that. So the nice thing about the immunotherapy drugs is that they work regardless of what your mutational status is. So it doesn't matter whether you're BRAF positive or negative, you're NRAS positive or negative, or any of those. They work regardless. So right now, Health Canada and the FDA has approved ipilimumab, IL-2, interferon, and pembrolizumab, which was just approved a few weeks ago. And these drugs, because they're not funded yet here in Canada or even here in Ontario, the nivolumab is currently available on a clinical trial that we have here at our center. The pembrolizumab, because it's now approved by Health Canada but not funded yet, the company that makes pembrolizumab has a patient assistance program available now that allows us to give the drug for patients until it gets funded. There's also new agents looking at the PD-L1, which was the receptor sort of on the other side of the T cell, and they're looking at ways to block this as well. And all these new drugs looking at PD-L1 are only in clinical trials. So there are clinical trials available for those drugs. So just to give you a little bit of background about how well these drugs work, the ipilimumab, the reason that this drug was approved and the reason that we really use it is because of not so much because of the response rates that we see, but really because how long the effect actually works. And they saw in some of the earlier trials that the response from these drugs for most people lasted for a very long time, much longer than 18 months, 2 years, and so on. And what they saw more recently when they looked at all the data that they had, they now have data going out to about 10 years since the studies started for these drugs. And what they see is that once you pass the 3-year mark, at 3 years there's about just over 20% of patients that are still alive that were treated with ipilimumab, and this effect will last for it goes out now to more than 10 years. So if you did well on this drug, chances are you're going to do well for a very, very long time. Unfortunately, these results always come with a price, so there are side effects associated with these drugs. The most common side effect with ipilimumab is a skin rash and diarrhea, but you can get what we call immune-related side effects because these drugs affect your immune system and really can affect any part of your immune system. And we'll talk a little bit more about some of these drugs and what we do to be able to manage some of these side effects. And then just to show you some information about the pembrolizumab, which is one of the PD-1 drugs, and these were results that were just updated recently at our ASCO meeting. And basically what they see with these drugs is that it benefits about just over 70% of patients. So if you're going to be on this drug, you have a 70% chance that it's going to work and have some benefit. And because these trials are still pretty early and these drugs are still pretty new, we don't have the long-term data like we do for ipilimumab. So, but what they do know is that at 2 years, 70% of the patients who started out on these trials are still on drug and still doing well. And that the median overall survival that they're seeing with these drugs is at 2 years. And that there's about 50% of people that are still alive and doing really well at the 2-year mark. And this is pretty incredible when we think about some of the chemotherapies and some of the earlier drugs that we had where we never saw results like this. And then more recently, they compared this drug to ipilimumab, and what they saw is that it is better than ipilimumab in terms of how well it works at shrinking down the tumors, as well as how long people live when they take the pembrolizumab compared to ipilimumab. So the hope is that as time goes on, and hopefully within the next year or so, that we'll have this drug that we can use before we have to use ipilimumab. And then the other PD-1 drug, which is the nivolumab, again, really impressive response durations. All these drugs, we see that they work for at least 2 years, much longer in a lot of the patients, with most patients being around for longer than 2 years that are on these drugs. So because we now have all these drugs that target the immune system, and we know that we're benefiting quite a large percentage of patients, obviously there's still a lot of patients that are not getting benefit from these drugs. So then the thought is, what if we combined 2 of the immunotherapies? Would this improve the chances of these drugs lasting longer and working better than if we just used one drug alone by itself? And so this is exactly what they did. They combined the nivolumab with the ipilimumab, and what they saw was that it is better than the ipilimumab by itself, and maybe even a little bit better than the nivolumab by itself, but this comes at a cost of much worse toxicity than either of the other 2 drugs by themselves. So we're really waiting to see the longer-term data from this trial because this is still fairly early on, and we really need to see what the longer results are in terms of putting patients through some of the toxicity that comes with the combination of these 2 drugs. So just to talk a little bit about some of these toxicities, and I'll just put them all up first because it's just easier. So because of the immune effects that they have, basically they can affect any part of your body. And what they do is they cause inflammation to any organ pretty well, including the eye, the skin, liver, wherever. But the most common ones, as we talked about before, were the skin and the diarrhea. So the chances of developing something like colitis when you're on these drugs is much higher with the ipilimumab drugs than it is with any of the PD-1 inhibitors. So the ipilimumab, there's about a 10% chance of developing colitis if you're on these drugs, whereas it's only about 1% with the PD-1 inhibitors. The other common things are the endocrine effects that it can have, so it can affect your thyroid and make you hypothyroid or hyperthyroid, which we've seen quite often, more so on the PD-1 drugs. Inflammation of the lungs can happen in about 3%. So all these things we watch very, very carefully when you're on any of these drugs, and we have a monitoring program that our nurses run which you get weekly calls to make sure that you're managing okay on the drugs and that you're not developing any of these side effects. Because the trick for any of these side effects is to not let it get to a colitis and not let it get to a pneumonitis. So what we want to do is treat things early so that you don't develop the bad side effects. And they are fairly easy to treat with high doses of steroids, and so we like to do that sooner rather than later. So just in terms of what clinical trials we have now, given all these new drugs and things that we have happening, in the adjuvant setting, we have the vemurafenib and placebo versus placebo trial that we talked about, the nivolumab compared to ipilimumab, which is the two immunotherapies, because of the good results that we see in the metastatic setting, and again, more immunotherapy trials because of some of the good effects that we saw. So there's one compared to interferon, which will be mostly the North American trial, which we will run here. There's also a pembrolizumab compared to placebo, which is mostly being done in the European countries, and some of the Canadian centers will be running this trial as well. In terms of the metastatic setting, Dr. Wright touched on this a little bit, and what it means to use neoadjuvant therapy is that if we have someone whose disease is too big to cut out, then if we have the option to use drugs to shrink that disease down to make the surgery a little easier and being able to do the surgery, then we will use drugs to be able to do that. So we're going to be doing a trial looking at patients that have BRAF mutations, that have bulky disease that can't be resected up front, and treating them with these drugs to see if we get better results. As I mentioned, we have the nivolumab trial that's open now that gives us access to this drug. We still have another BRAF trial open looking at combination of drugs, and we will have more exciting things happening down the road. One of the things is that because we know that these targeted agents, such as the dabrafenib and trametinib, work quickly to shrink tumors, and we know that the PD-1 drugs work well and they work for long periods of time where these other drugs don't, there's been a lot of research looking at, can we combine all these drugs to see if we can get the best of both of those effects? Something that works really fast and something that's going to last a really long time. So we do have a trial that's opening up this fall that's looking at pembrolizumab, the PD-1 inhibitor, compared in addition to the dabrafenib and trametinib versus just the dabrafenib and trametinib by itself. And then I mentioned we have the nivolumab. Because of the new trial that I just showed you in the combination of nivolumab and ipilimumab, we will have an access program that will be opening that'll give us access to using this combination of drugs probably very soon. So how will the PD-1 drugs and just the amount of research that's going on currently in immunotherapy, how is this going to change how we treat melanoma? Well, now we're seeing control rates that are greater than 70%. We know that these drugs work a little bit different than all the other drugs that we've had up until now. We know that it even works a little bit different than the ipilimumab because it works much faster and things last a really long time. We also know that the toxicity is a little bit better. We don't get as much of the immune side effects that we get with ipilimumab. But we really need some of the longer term follow-up in terms of how patients do years down the road, which we won't have for a little while. And we talked a little bit about combining these drugs to see if we can make things better. But the great thing about these drugs as well is that it doesn't only work in melanoma, it works in many other cancers such as renal cell cancer. There was really good data for lung cancer that was presented at ASCO. Bladder cancer, head and neck cancers. There's all kinds of cancers that are benefiting from these drugs. And that's great for everybody. And then we'll have the adjuvant trials that are going to be starting because of the good results that we've seen so far. And then just to finish up, so as I mentioned, there's been a lot of progress that's been made over the last 5 years. You know, we started out in 2011 and really back to the 80s when we've had DTIC for 30 years. Where we had just chemotherapy, where we knew the response rates were only about 10% and they only lasted for a few months. And we moved on to some of the targeted therapies where we saw really high response rates where it benefits more than 80% of patients. However, the duration or how long these effects would last was cut short, mostly because of the resistance that the tumors build. And then they figured out how to overcome this resistance with the combination of therapies, where we now see better responses, longer duration of response, and patients doing very well for long periods of time. And then from that, we moved on to the immunotherapies, where we're seeing good response rates and really long duration of responses with these drugs. And hopefully, I mean, for all of us, we all hope that all this translates into the adjuvant setting, where we can really make a difference and hopefully cure patients of melanoma. Thank you very much.